Thanks very much for inviting me. I'm Henry Lee, a radiation oncologist in New York. My talk today is a little different from the rest of the forum. Like the others, it's intended to help us provide better care for our patients, but it's not about a specific disease process. Rather, the talk is meant to help the oncology community better communicate to their patients about an seemingly arcane treatment that over half their patients will receive, but few in the community are comfortable explaining, and that is radiation therapy. Now, the word cancer is intimidating enough. It strikes fear, even into all of our hearts, and none of us like saying it. I think there's an old comic, it might be a Far Side, where a physician tells a patient that he's going to die tomorrow of a heart attack, and the patient happily says, well, at least you didn't tell me it was cancer, or something to that effect. Radiation therapy is one of the three mainstays of cancer therapy. We, of course, have our medical oncologists using cytotoxic chemotherapies, targeted agents like immunotherapy, and related therapies. About 75% of all patients will get systemic therapy. We also have our surgical oncology colleagues who use their proverbial scalpels or fancy robotic techniques to very effectively manage about half of all cancer patients. And then we have the arcane field of radiation oncology that's hidden away down in the basement and that only a few patients receive, right? But people don't realize that over 2/3 of all cancer patients receive radiation therapy, and that the majority of them, the large majority of them, receive radiation therapy with curative intent. And of all the patients who achieve a curative outcome, about 40% of them received radiation therapy as either the definitive treatment, such as SBRT, or in combination with other modalities. So how do we explain radiation therapy? Well, to start with, let's start with what it's not. It's not radioactivity. At least that's not what the vast majority of patients are getting. Most of those radiation therapy or most of those radiation warning signs you see in the department have the same meaning as the ones in your dentist's office. Most patients, and I'm talking 99%, get external beam radiation therapy, and therefore they're not radioactive. Put another way, we're actually treating them with photons, not protons, by the way, that's another talk. Now, photons with a pH aren't torpedoes. What they really are is a type of energy wave, not water energy waves that can reach the power of tsunami, or seismic energy waves of earthquakes, or even just sound energy waves that cause vibrations. Photons are a type of energy wave that is far more familiar to patients than they realize and are actually part of their normal daily life. Photons are otherwise known as electromagnetic energy waves, EMR, like the ones that are bathing you right now. And that's what we're going to call photons for the rest of this talk. The electromagnetic energy wave, or EMR, you're most familiar with, and probably flipped on the first thing you did this morning, is light. So in radiation oncology, we are literally using high energy, quote unquote, light waves to kill cancer cells. There's nothing nefarious about that. How is that simple light bulb on the left related to that fancy cancer treatment machine on the right that's packed with an insane amount of high-tech physics and robotics? That linear accelerator, or LINAC on the right, is based on the principles of the lamp that you flipped on this morning. That lamp is plugged into the wall. Electrons go down a wire. They hit the tungsten filament of a light bulb, and out comes a weak form of electromagnetic energy waves known as visible light. The linear accelerator on the right works on the same principles. It plugs into the same power grid, plugs into the wall. Electrons go down a tube instead of a wire, hence linear. And as they go down that meter-long tube, they go past a series of magnets, electromagnets, that speed up the electrons from zero, so to speak, to nearly the speed of light, hence accelerator. And once they reach the end and hit the tungsten filament that's a lot bigger than a light bulb, out comes much, much more powerful energy waves, electromagnetic energy waves that are at the extreme end of the power spectrum and meant to kill cancer cells, to treat cancer. Energy waves are otherwise known as electromagnetic energy, EMR, all around you. When those waves are hundreds of feet apart, you know them as radio waves, and they radiate from a radio tower. The magic happens when you start to compress those waves. When those waves, energy waves, EMR, get compressed to say a few inches, they become microwaves. Compress them even more, it becomes heat, infrared, radiating from a radiator. And essentially we're using radiant energy to treat. So when infrared gets squeezed even more, it goes from infrared to red, yellow, blue, green, violet, visible light. And you can see what happens as you squeeze the waves in front of your very eyes. Then you get to ultraviolet, and then this really sort of broad area that they just called X-rays. Now, when they're at sort of the red equivalent of X-rays, you know, the weak end of the X-ray spectrum, those are the X-rays that radiologists use to look for cancer cells, whether it be a chest X-ray, a mammogram, which is a weak X-ray, or a CAT scanner, which is just a X-ray machine that goes around in a circle and is hooked up to a computer. When we use our linear accelerator to squeeze those waves down to about as narrow as they can get, like cosmic rays, about the width of an atom, those are the X-rays, the photons, the electromagnetic energy that we use in radiation oncology to kill cancer cells. And literally, they are high-powered X-rays. Now, how does a radiation therapy work? It doesn't disintegrate things. It doesn't vaporize things. We're not quite there yet. Now, the concept is that since these energy waves are about the width of an atom, that's what they interact with when they enter the body. And when you hit something, you always hit the outside. When you get punched in the face, you hit the skin before you get to the bone. When you hit an atom, you hit the outside. And what's on the outside? Electrons. And so that energy wave gets transferred to an electron that literally becomes an atomic bullet, goes flying out and breaks up the DNA strands of the cancer cell. Now, since water is the number one molecule that these X-rays are interacting with, the process is called free radical formation, right? Because of all the oxygen. And therefore, the mechanism of action, free radical formation, oxidation, it's exactly the same mechanism that many chemotherapy agents utilize. So radiation therapy is in part a lot like surgery in that it's a directed therapy, and it's a lot like cytotoxic chemotherapy in that it's using, again, free radical formation, oxidation to kill cancer cells, a chemical reaction. Again, no radioactivity. Patients aren't radioactive. They can be around anyone. They can be around babies. They can hold babies. They can be around someone who's pregnant. There's none of those precautions for them. Now, those high-powered X-rays, again, are breaking up the DNA even more than what it already was, so that they can't divide, they can't live, they die off. But just like after an antibiotic kills off bacteria, say in a lung infection, it's your immune system that's going to take away the dead cancer cells. And in fact, radiation therapy relies heavily on your immune system to, again, clear out all the dead cancer cells. And it's part of the reason why it takes days, weeks, months for the effects of radiation therapy to fully manifest themselves. And in fact, radiation therapy is one of the most powerful potentiators of the immune system known to mankind. And typically, radiation therapy enhances the immune system. It doesn't suppress it. And again, it relies on the immune system to remove much of the dead cancer cells.
How the linear accelerator works. All body cells can be damaged or killed by radiation, but tumor cells are more sensitive to radiation than normal cells. Radiation therapy uses this principle to damage beyond repair or kill the abnormal cancer cells in a tumor. Successful radiation therapy depends on the ability of the linear accelerator, or LINAC, to deliver a tumoricidal dose of radiation to the tumor, while ensuring minimal radiation of normal tissue. The LINAC accurately produces, monitors, controls, and conforms the radiation beam to the planned target. Beam generation. Radio frequency waves are pulsed into the waveguide by the magnetron. This is synchronized with the injection of electrons into the waveguide by the electron gun. The radio frequency waves accelerate the electrons along the waveguide to a speed approaching the speed of light. The X-ray beam is created when the electrons hit and interact with a tungsten target at the opposite end. The magnetron controls the power and frequency of the radio frequency waves, which determine the energy of the X-rays produced. The high-energy electrons hit a small tungsten target where the electron energy is converted into photons, or X-rays. The high-energy photons emerge from the target in a variety of directions. The primary collimator only allows forward-traveling X-rays to pass through. The X-ray beam is almost ready to treat the patient. Before that, further beam shaping is required to ensure that the shape of the delivered X-ray beam matches the shape of the tumor. This is done using a multi-leaf collimator, a number of fine tungsten leaves which move independently of one another and can create a variety of complex treatment shapes.
To understand how radiation therapy has become safer and more effective over the years, we need to focus on the concepts of treatment and drop attention to marketing terms and acronyms like IMRT and VMAT and CyberKnife and EDGE and SBRT. The first concept is that more beams of radiation therapy in general gives us less dose through each beam, and with that less dose to the normal structures in the path of that beam has increased the safety of the treatment and thereby let us give more dose to the cancer target and thus increase the likelihood of cure. That concept is illustrated on this slide. This is an example of the evolution of prostate cancer treatment over the decades, from 1980 on the top left to the 2020s on the bottom. In each box of the axial CT cuts, the prostate is outlined in green, and the key critical normal structure, the rectum, is just below it. The easy part of radiation therapy is treating the target. The hard part is sparing the normal structures, as you'll see below. The redder an area is, the more dose it's getting, and thus the larger the red area is, the more critical normal structures are experiencing toxicity. In the 1980s, at the top left, we were using only 4 beams of radiation therapy, each giving 25% of the dose. And as you can see from the large area of red, representing a large high dose area, the treatment we delivered in the 80s treated as much rectum as prostate. And it didn't help with the reputation of radiation therapy. As each decade went by, from 1980 to 1990 to 2000, we used more and more beams, going from 4 in the 1980s to 6 separate beams in the 1990s to the 2000s, where each of the 6 or 7 or 8 beams was actually divided up into thousands of smaller beamlets. And then the 21st century, where we used an infinite number of beams. How did we do that? The machine went around in a continuous circle, constantly delivering radiation therapy and constantly changing the shape of the beam. And as you can see, for each passing decade, the red area became smaller and smaller, demonstrating that the amount of normal tissue, especially the rectum, was getting less and less radiation dose, whereas the prostate in the middle was receiving the full dose. By increasing the safety of the treatment by giving normal structures less dose, such as the rectum, we were able to increase the total dose of radiation therapy, going from 32 small treatments to a total dose of 5,760 in the 1980s, to the mid 6,000 range in the 1990s, to over 8,000 centigrade in 2000, delivered in a total of 45 small treatments. Now, 45 treatments represents 9 weeks, and in reality, 10 weeks of radiation therapy for most patients. Not so bad if you're on the Upper East Side of New York, but in the real world, a pretty challenging thing to do. So in the bottom row, what we started to do was that as we, again, continued to improve our technology, rather than giving more little treatments, we started to give more dose each day and cutting the total number of treatments that were required. And so in the bottom panel, we went down to 28 medium-sized treatments and then 5 large treatments. And again, making the fields more and more tighter, conformal, and treating less and less normal tissue and making the treatment safer without compromising efficacy. Now, those with sharp eyes will notice the following: that the dose was going up and up and up in the top panel, and then went down in the bottom panel, down from 8,000 down to 7,000, and then down to the 3,500 to 4,000 range for SBRT. So how can 3,000 to 4,000 work as well as 7,000, work as well as 8,000 centigrade? And that's because we're talking about energy. We're used to thinking about physical quantities, like a cup of water. A cup of water is a cup of water, whether you drop it in a dropper at a time or a tablespoon at a time or splash it all in, it's a cup of water. Energy is different. I can tap somebody on the shoulder 1,000 times, they probably won't really feel it, or I can pack it into 2 or 3 larger pushes, larger punches, and you'll feel it. It's still the same total dose, but the impact is completely different. So the amount that you deliver with each treatment, the amount of radiation therapy delivered with each treatment makes a big difference. A little bit more each time accomplishes a lot more. And so the biological effect of 45 small treatments is the same as 28 medium-sized treatments, is the same as 5 large treatments. And the toxicity profile stays the same all the way across. And just to go back to one thing, the number of beams, the more beams you have, the fewer side effects, because the more conformal treatment, because the less amount of radiation coming from any direction. It's just like a light. You can be on a stage, you'll be with one big bright spotlight, you're lit up, you're hot, you feel the side effects. You can be on that same stage, be lit up with lots and lots of little lights, you'll be just as bright, but you won't feel it. It's the same principle as what we've done for radiation therapy. So again, more beams, less toxicity, more dose each day, delivered through more beams, results in a treatment that ultimately is more effective and safer, as well as convenient, and takes a less toll on society. To sum things up, radiation therapy uses a linear accelerator that is based on the principles of a lamp. It uses healing waves of high energy light for all intents and purposes. It truly relies on the immune system. It doesn't suppress or replace or destroy the immune system. It needs the immune system to do its job. It works a lot like chemotherapy in that it causes a chemical reaction. It works a lot like surgery in that it's a targeted therapy. And it's faster and safer than ever. So thanks very much for your time.